get Americans talking about mental health, to break down misperceptions, promote recovery in healthy communities, to find innovative community-based solutions, and for some groups to develop clear action steps for communities. And we've had a series of webinars. They're on our website, which is on the next slide you'll see is a website where you can find out where community conversations are happening, and many resources, including tapes of previous webinars and slides, which you will be able to access for this one. Today we're very fortunate to have Dan Berstein do a webinar for us. Dan is a mediator who's developed mediation around issues of mental health. He also is the first person to hold a community conversation that was not one of our lead sites in New York City. A few weeks ago he'll speak about that, and he's going to be talking about welcoming and appreciating diverse mental health perspectives. So without further ado, I'm going to turn this over to Dan. I will be back only if there's some questions about creating community solutions that I can more easily answer. You may also hear Raquel Goodrich, who is our wonderful tech person who is receiving questions and so forth from you. So Raquel and I will mostly be quiet, and Dan, welcome and thank you.
Thanks, Mary. So let me start by giving you an overview of what I'm going to talk about today. So if we can go to the next slide and look at the agenda. So today I'm going to talk to you about mental health perspectives, and I'm going to give you my definition of what are mental health perspectives. I'm going to introduce you to the medical model of mental illness and share some information about some of the uncertainties involved so people can understand the importance of being open-minded to more than one point of view in mental health. Then I'm going to discuss some of the language in mental health. So I was personally diagnosed with bipolar disorder about 8 years ago, and in that time I've been part of a number of different mental health communities, and I've learned a lot in those 8 years of different languages and different ways people talk about it. And so I'm going to try to give you a crash course so you can be familiar when running your event, and you won't be surprised by the language like I have been over the years. Then we're going to talk about some lived experiences in mental health. I normally do a longer presentation about that, but I'm just going to give you a short snippet of what that looks like. And finally, we'll end with ways to welcome diverse perspectives to these events. So one thing I want to point out is you can ask questions throughout the presentation. I don't mind the interruptions, so just type those questions in, and then Raquel will read them before advancing the slide, and that way I will be able to answer questions throughout instead of just at the end. So today's goals. First, I want you to appreciate that there are multiple perspectives in mental health. So a lot of people, when they hear about mental health or they hear about mental illness, they think it's just one thing and it's a concrete idea and there's one way of looking at things. And the reality is there really are infinite different points of view that have to do with a lot of factors. And I want to just open your mind to that. There's more than one way of looking at things. Then I want you to become sensitive to some of the language and some of the experiences related to mental health. This is a short webinar, so it's not going to cover everything, but the idea is to expose you to some things so that way you're more aware, and all of this is to really just maintain an open mind to the different points of view that are coming to these events, because as a facilitator, we want to be welcoming all these diverse experiences and perspectives, and we want everyone to feel welcomed and validated. And that's the last point here, is to make sure that we walk away knowing that we're going to validate and empower all the perspectives that come to a dialogue event. So the next slide. So a couple of reminders, and I've said this, I'm gonna really just keep stressing this. This webinar is meant to open your mind to different ways of appreciating mental health. So it doesn't offer answers. I don't want you to walk away from this webinar thinking, now you know the right way to say this or the right answer to that. These are just some ways that some communities have different perspectives about things, and it's just meant to make you aware of some possibilities, but not give you definitive answers. And the other reminder that I'm going to say throughout is to be open-minded and be neutral. So please do the next slide. So this is a picture of the event that I held in New York City. MH Mediate is my group, and we co-sponsored this with the CUNY Dispute Resolution Center. They provided the space at John Jay College. And if you go to that URL below, you can see a lot of resources recapping our event and also giving you tips of how to plan your own. The key thing that we stressed in our event, and the key thing that made our event special, was we reached out to a lot of different perspectives, ranging from mental health professionals to people with lived experience. And I want to also stress that people with lived experience can be a lot of different points of view as well. So we reached out to people who have diagnoses and have past experiences, but are affiliated with a variety of different groups. And not all those groups have the same ideologies. So the idea that, measuring diversity in terms of whether someone's a provider or whether someone's a service user, that's not the end of the process, because there's also people with different perspectives within those groups. And there's also overlap across those groups. So there's people who came who were mental health professionals as well as supporters of loved ones with mental health issues, and they also had mental health issues themselves. So this was really a very diverse event, and we were able to have a successful event because we emphasized neutrality across all these perspectives throughout, and we made people feel like the goal here wasn't to come up with a right answer of what to do with mental health or how to look at it. It was for everyone to share their ideas and share their personal brainstorming and collect it together without deciding what's the right way to look at things, what's the wrong way to look at things. Because really there is no wrong way to look at things that I know of, at least in my experience. Next slide, please. So I want to now answer the question of what is a mental health perspective. And this is my own terminology. I didn't get this definition from a dictionary, but a mental health perspective is really a point of view. And there's many different perspectives in mental health because there are no clear answers. So mental illness is not well understood. It's considered to be the final frontier of medicine, psychiatry. No one really knows what's going on and where to draw the lines between, a quote-unquote chemical imbalance or whatever the different theories are. No one really has a clear answer on how you parse a mental health issue, and so that leads to a lot of different perspectives in mental health. It's hard to define and measure. So there's a lot of different ways people define mental illness, and there's a lot of different ways people measure if someone's experiencing instability of some kind, and all these vagaries and ambiguities they breed a lot of different points of view. So there's also many different approaches in addressing mental illness. So you can go to different kinds of mental health professionals, whether it's a therapy or medication, or whether you go to an alternative or a mainstream approach. So all of those lead to different perspectives as well. And there are people who see their sensitivities as a difference and not an illness, and that's an important point to remember. I identify as having bipolar disorder, but I certainly don't abide 100% by the medical model, and I'm one example. So there's a lot of people who interpret their experiences in different ways, and that also leads to different points of view. So let's look at the next slide. Now, perspectives can be different based on the role that someone has in the system. So if you're a mental health professional or a family member or a person with lived experience, again, like I said before, it's not that simple, and there's differences of opinion amongst different mental health professionals and also within their own profession. So there's all sorts of debates that go on. The ideas about the nature of mental health problems can lead to differences in perspectives. So people have different ideas about what causes their mental instability, and people have different ideas about diagnosis. I'm going to talk in a minute about some diagnosis controversies that are happening lately, so you can understand that it's not clear-cut. People have different perspectives based on their views about rights. So, a big example of this is forced treatment. Should we be forcing people into the treatment, or should we be respecting their decision not to get treatment? That's a very, very difficult question when you're wondering if someone needs help and doesn't know it. So, and that can cut across things in different ways. On the one hand, it can be considered a rights deprivation to insert your own point of view. On the other hand, it could be considered supportive to go help someone who's in trouble. And then views about what kind of treatment works. So that's the medical model, alternatives, different approaches within the medical model. So all of these are different perspectives. I'm going to pause here and remind you that you can ask me questions at any time. You can type something in and it'll be read aloud to me and I'll answer the questions. But this has been my introduction to mental health perspectives. And now we'll move on to the next slide and talk about the medical model. So what is mental illness? So there's no single definition that I've found that definitively describes mental illness. Different people, different organizations have different definitions. The definition that I used in some presentations a year ago and that I've used since then is a mental illness is a problem thinking, feeling, or relating to others that persists, so that means it lasts for a long time, and that disrupts, which means it's messing up some kind of goal, whether it be your ability to work, your ability to form relationships. But that's a pretty vague definition, and that's the best definition that I'm going to give you today because I don't know where to take it from there. There's a lot of different points of view, and the diagnostic system that we have, that I'm listing on a slide here, the diagnostic system proposed by the third bullet, the Diagnostic and Statistical Manual of Mental Disorders, is under question now. I'm sorry to go out of order on the slide. So the second bullet has a quote from Dr. Ken Duckworth, who is the NAMI medical director. NAMI is the National Alliance on Mental Illness. And his quote is that diagnoses are reliable, but they might not be valid. So what that means is 4 out of 5 mental health professionals will probably agree that I have bipolar disorder. The diagnosis is reliable in the sense that everyone will agree the same person has the same diagnosis. But we don't really understand if there is such a condition as bipolar disorder, if that's really the story, or if that's just our best guess, because we haven't really figured out what's going on with mental illnesses, biologically, and so that's what it means that it might not be valid. So this slide, and I'll pause here. Please type questions right now if you have any. The point of this slide is just to open you up to the definitive ideas of what is mental illness in the medical model, and to see that it's open. It's open-ended. There's a lot of things to be figured out, and there's a lot of vagaries to it.
Dan, this is Raquel. I haven't received any questions yet.
Okay.
But, do feel free to go ahead and type those questions into the chat box, and I'll be watching for them.
And don't feel pressure. Don't make up a question if just to please me, because if everyone's with me, then we don't need questions. That's fine. But if you have a question, definitely share it. So let's move on to the next slide. So going on with the theme that there's a lot of uncertainty with mental illness, I just want to share with you 5 points to help you, again, maintain an open mind when looking at mental health issues and mental health problems. So the first 3 are all related to labeling what is a mental illness. The first bullet point, and it's got a link. I'm not sure if you're able to click it through this webinar, and if you're not, we can arrange to grab it and send the link to you afterwards. But the link is a letter written by the people in charge at the National Institute of Mental Health, which funds a lot of mental health research. And what happened is they rejected the Diagnostic and Statistical Manual. So the latest edition came out, the DSM-5, and the NIMH said, you know what, you're classifying people based on symptoms, but you really don't know what's going on, and we want to fund research a different way because we want to actually look for what's going on. And so they proposed an alternative scheme to look at and measure mental health issues. So that's a recent controversy. It's very important to just keep aware that there are different ways of classifying mental illness and mental health issues. The second bullet point is the question of overdiagnosis. So there's a lot of debates amongst mental health professionals. Where do we draw the line and say that someone is experiencing an illness versus some kind of normal variation in traits? So are we pathologizing people? Are we saying that people are diseased too easily? And is that happening because the pharmaceutical industry is influencing it, or for other reasons? Are we diagnosing people too much? And a third debate is about treating children. So there's a question of overdiagnosis in children, but there's also a question of whether our treatments work in children. So if all of our treatments have been tested in adults and now they're being prescribed to children without having been studied for children, is that a good idea? And are some of the issues that children are experiencing, are they related to developmental changes? And they might not necessarily be permanent, but now they're being saddled with labels. So these are all questions that people have had about deciding if someone qualifies for a mental illness and what that label means. And I just wanted to share that, not to take a side on any issue, but so as facilitators, people are aware that the construct of mental illness, the idea of mental illness and mental health, is not as robust as some people might think as a layperson. The other 2 bullet points here are about cultural issues. So for those of you who don't know, homosexuality was a disorder until 1973. And that's an example of how the mental health system can be used to oppress someone's behaviors, and it's not necessarily an illness per se, or we wouldn't say it's an illness now, but culturally, it's a tool of cultural oppression, at least for homosexuals up until 1973, but there's a lot of other historical examples of the mental health system being used in that way. And nowadays, there's some studies that show that black patients are twice as likely to be diagnosed with schizophrenia despite no higher incidence. So what that means is that our system is set up so that culturally we're not, it's set up for one culture, and it's not being applied well to another culture. Based on the studies that I've read, that's the conclusion that they reached. So these cultural issues are also important just to understand. There's a lot of nuances here, and a lot of variation, and just a lot of uncertainties and a lot of issues. So the next slide, please.
Dan, we do have a question that just came in from the audience from Teresa Miller. And her question is, when treating clients, how do you suggest explaining the challenges of labeling debates? Often I may diagnose a client with something different than their previous diagnosis, and this can be confusing to clients.
Well, thank you, Teresa. So my understanding for this presentation is that the audience is people who are going to create these Creating Community Solutions events. So people who are going to be inviting dialogues and conversations. And in that realm, I would advise never to make a diagnosis, because none of us are treating people. But what you're saying is an example. What your question is, how do you teach someone all these complexities? And I'm working on it. I'm going and giving webinars to all sorts of people and trainings, and trying to get people to understand that it is really complicated. In your situation, it might not even be one of these labeling debates that I talked about, but it could just be that you and your colleague who already diagnosed the person have different philosophies personally within the profession. Even if you follow the same system, people can come to different conclusions, or you never. So it's a very complicated question. I think my answer is I do this. I show people lots of different points of view so they understand that it's really hard to come up with a right answer with mental health. And that's what I do. So you're seeing a short version of what I do to explain to people we shouldn't be clinging to any one system because no one really knows for sure what's going on. That's my personal philosophy. But in this event, I wouldn't suggest we diagnose or explain diagnoses to anyone. I would hope that facilitators are just aware that there are all these different ways to look at things, and we should be validating everyone. So I guess I would say, you know what, this is my diagnosis for you if I were in your situation, but if I'm validating everyone, I would say that other person had their own point of view, and it's valid to look at their point of view either, and you have to decide which person you choose to go along with. That's the philosophy that I would apply, if that makes any sense. Are there any follow-up questions to that?
I haven't received any yet.
Okay, so let's do the next slide. And the next slide is, we're going on to a different section of the talk, and we're going to talk about language that you might encounter when running a dialogue event. So there's different words that people use to talk about lived experience of mental illness. And I'm going to tell you 5 of them, and I'm going to tell you the definitions that I've heard. But be ready to hear any kind of definition, because people use words different ways. So the first is patient, and I always start with patient because all these words evolved first from people being some kind of mental health patient. And I just want to say that mental health patient is someone who's undergone treatment for mental illness. And when I was in the psych ward, I was a patient. But in general, my understanding from the communities that I've been a part of is people do not like to call themselves patients because it seems like a disempowering term. So unless someone calls themselves a patient, I would steer clear of using that word, and I would look for some other kind of terminology. I have no answer to you of what's the right term to use when talking about mental health. I always offend somebody, so I have not found the magic words, but I'm just teaching you some of the words that people use. So the next term is consumer. And the idea of consumer is I'm someone who is using mental health services, but I'm not a patient. I'm choosing my own services. I'm empowered. And that's as I understand it, the definition of consumer. And so a lot of people will identify themselves as consumer. You'll hear people talk about in a consumer-run organization, or the board of my organization is over 50% consumer. and that's the term. The next term is peer. So lately, what I've noticed is the term consumer is going out of fashion, and the term peer is becoming more popular. And the term peer does not mean peer in the sense that, oh, I have bipolar disorder and you don't, and we're still peers. So meaning we're all on the same page. Peer means people who have experience with mental illness, who identify as having experienced the mental health system. So it's only people with mental illness who would be considered peers if you use that definition. And there's a few different definitions going around. So there's actually an association of peers that's proposing a new definition, and they won't use the term mental illness because a lot of people don't like the term mental illness to begin with, and so they refer to a condition, and they've experienced stuff because of a condition, and that's the way they did it in their definition. So it's very complicated, these language issues, but the important thing is if you're at a dialogue event and someone says, oh, we're consumers, or oh, we're peers, that maybe you'll understand a little bit more what that means. That the word peer means that the person is likely to have lived experience of mental illness, and when you hear of a peer-run organization, that's people who have been living with some kind of mental health issue or some exposure to the mental health system. Now there's people who are going under the term family peer. My screen just cut out, so did everyone hear me?
Yes.
Okay. And my screen is back, but so people are saying that there's family member peers as well, but usually peer means the person with lived experience. The next term I'm going to use is survivor. Survivor is also a pretty popular term, but it depends on where you are to hear someone call themselves a mental health survivor. When I talk about what a survivor means in the context of mental health, sometimes people use it as a survivor of a suicide attempt. So they might say, I'm a survivor, and that's what people usually guess. Or survivor in the sense that I had an episode of mental illness and now it's subsided. So just like a breast cancer survivor is in remission, a psychiatric survivor would be in remission. But the way that people who call themselves survivors usually mean the term, from my experience, is similar to a Holocaust survivor. So the idea for a survivor is I've survived the mental health system. I survived being forcibly drugged. I survived being tied down in restraints. I survived being treated like I was less than a human being. And I don't use that terminology to describe myself because it feels a little harsh. But at the same time, I actually am a survivor in the sense of all those things. So I have been forcibly medicated. I have been tied down to a bed before, and I have been treated like I was nothing because I had a mental illness. And so the language survivor really resonates with me, but because it's polarizing, I don't use it. So I'm just sharing that with you so you can understand that it might seem so surprising to hear the term survivor, but it's an experience that a lot of people, whether or not they call themselves survivors, might still identify with because of their personal experience. And so to be aware of that language and the history is important. The last term I'm going to say is person using mental health services or a user. That's that's basically my way of understanding that. And obviously this is just my opinion on all of these terms. So there's a lot of different ways people can describe them. But someone who's saying they're a person who used mental health services wants to identify as having experienced the mental health system without buying into it. So if I say I use the services, that doesn't mean I agree with the medical model. Whereas if I'm a consumer, it might sound more like I agree with the medical model. So some people call themselves users of the mental health services or someone who's been diagnosed, but because they don't want to agree with the diagnosis or agree with the service. So those are some terms. I'm going to give you a quick rundown of some other language as well on the next slide, please.
Before we go to the next slide, we have a question that came in about it's about a term that's not on this list.
Okay.
From Tim Crowley. Why change from client to consumer in mental health? To me, clients purchase services and consumers buy things like pills, not therapy.
Yeah, well, so I didn't include all the terms. So there's terms like recipient, there's terms client. I don't have enough time to give my whole spiel about this, but I used to make a joke that every time, a lot of people that I know who identify as peers really don't like the term consumer, and they say, I'm not buying detergent, I'm not buying groceries, I'm not buying, blank. Everyone has a different, I'm not buying something. Everyone's not buying something. They have different ideas, and that's their joke. And so why change all these terms? I don't have an answer for you on that. That's not the, that's just such a complicated question. These terms evolve over time. They're confusing, and no matter which term I use, I end up offending someone somewhere. And it's a challenge, and I'm sharing it with all of you to be ready to encounter those terms. But client is another term that people use, and I personally have used all these terms at different times, and I'm always trying to understand them better. And if anyone has any ideas, share about other terms as well, feel free to contact me afterwards. I don't know, but my email's at the end of the presentation, and the slides will be available afterwards, so you'll have the opportunity. Any other questions?
Nope, not this time.
Okay.
Oh, actually,
so this.
I'm sorry.
Oh.
I'm sorry. One did just come in.
Okay. Let's.
Let me go back.
Yeah.
This one's from Jennifer Wilding. Given the various terms that people use and the desire to avoid excluding or ticking anyone off, how do we acknowledge the various terms without getting paralyzed by them?
So I'm going to talk to you about this for the day of event tips that are at the end of the presentation. But here's my short answer. I told everyone at our event that we have a lot of people here, and it's a diverse representation of people with a lot of different points of view, and it's very sensitive. And everyone's here because they care about mental health, but obviously people have differences of opinion. And so one of the guidelines that we have for our discussion groups, and one of the guidelines that we have for the event today, is we're going to assume the best intentions from everybody. So if something's coming up and it sounds offensive, let's all try to assume that we're all here with good intentions, even if we have different points of view and different terminology. So let's try to educate each other and talk with each other and assume the best intentions throughout. And so that's what that's the one tip I have. The other tip is to never declare one term the right term. So never lock into any single perspective, but make it a group goal. It's a goal for everyone that we have a diversity here, and we're all trying to include everyone and work with that. So we're not coming up with an answer. We're coming up with ways to connect together. So that's the tone that we set at our dialogue, and it worked out very well. So this slide is a quick one. The way to talk about mental illness, you might hear people say he is schizophrenic. That's offensive to most people. People like to use what's called person-first language. So if I say I have bipolar disorder, that's different than saying I am bipolar. So I'm not defined by my illness. It's just something I have. Or some people would say I have a bipolar diagnosis, or I've been diagnosed with bipolar disorder. So that level of separating the person from the illness is important. And when talking about people, that is, there's very few rules of thumb I can give with language. One quasi-rule is avoid calling someone a patient unless they use that language first and they seem comfortable with it. But a really firm rule that I use personally is always use person-first language and say the person has bipolar disorder or has a diagnosis of anxiety, instead of saying, well, anxiety doesn't work, but has a diagnosis of schizophrenia, instead of saying they are schizophrenic. So that's a tip for all of you. Like I sometimes choose to say I am bipolar, but because I have bipolar disorder and it's my life, I can do that. When it's someone else, I would never say that person is bipolar, and that's because I've seen so many people get offended by it. So next slide, please. So this is quickly just to give you an idea in case it comes up. There's a lot of different ways that people describe tough times that they've experienced that are related to mental health issues. And if you don't know the lingo, you might not realize that someone in your discussion group is using these terms to mean that they experienced what would be classified by some as symptoms of mental illness or just serious problems. So one example is I'll say I'm sick or I'm feeling sick. And when I say that, I don't mean I have a cold or I have the flu. If I say to my sisters or my loved ones or whoever, I was feeling sick that day, I mean I might be experiencing symptoms of mania or high energy. Or I might be experiencing symptoms of depression, of low energy. So the term sick can be used to describe that kind of language or that kind of situation. Episodes is another terminology that comes up a lot. So I'll describe, it depends on what someone's experienced, but for me, I have discrete periods of time that I'm very sick, and I might call that an episode. I might use the language of symptoms. I might say that I was overwhelmed. I might say I'm sensitive. these are a few highlights. In my normal talks, I go on to say a lot more about this. The idea here is just to, as a facilitator, be aware that there might be some important content being said that you're glossing over because you didn't realize that some of these terms might mean a lot more than they sound on their face. And so this is just a quick intro to that concept, and it's something I would suggest preparing facilitators to do as well. I would suggest having facilitators watch this webinar so they understand that the name of the game is let's not make any assumptions of what someone means when they say that they're a peer or when they say that they were sick. Let's be open to asking some follow-up questions and not feel like we know what that person meant when they said that. So next slide, please. And then there's also something called recovery. There's a language that you'll hear now called about recovery. So what is recovery? Well, recovery means that if I'm experiencing recovery, I'm not really very sick from my mental illness. I might be taking medication all the time. I might have some symptoms, but I'm able to manage what's a full life for me. Recovery, by the definition of recovery that's in vogue now, recovery doesn't mean you're cured, and recovery doesn't mean you're living the same life you would have led before you were diagnosed with mental illness. So sometimes people will say, my recovery means that I can work 3 days a week. I thought I was going to work 5 days a week. That was too much for me. Now I'm working 3 days a week. That's my recovery. So that's the idea of recovery. Why did the recovery movement come to be? I just wanted to share this because I think it's an important perspective to have. Originally, people would get diagnosed, let's say, with hearing voices, and they might be put into a hospital, put on very heavy drugs. They might gain 100 pounds and wind up sitting still, drooling most of the day, not talking to anyone, but they no longer heard the voices. And so that was a success. They stopped hearing voices, and the treatment goal was to remove the symptoms. So the idea of recovery was saying, wait a minute, success is not removing symptoms. Success is achieving the highest quality of life you can achieve. And that's the vision of recovery. The recovery movement is saying, just because I have mental illness doesn't mean I'm now a chemistry project to try to remove the symptoms at all costs, and that's the only goal. The goal is for me to have a full life, and that's the recovery movement. And just one quick aside is, any of this stuff can become belittling. So recovery can become a belittling thing if my physician or if my psychiatrist says for me to have recovery, I can only work 3 days a week, but I say I want to work 5 days a week. That's where it gets to the point where recovery, the language of recovery can sound really good, like, oh, your recovery means you can work 3 days a week. But if someone's still sort of keeping you from your goals, it might still come off as belittling. So a lot of this positive language can still end up treating someone in a way that they get offended, and that's important to know because there might be people at the event who are talking about recovery and get upset at the way that people have defined their recovery for them. I'm going to pause here if there's any questions about that, because I know that as I was talking about this, it sounded confusing. So, are there any questions? Or is everyone with me?
No questions yet.
Okay. Well, feel free to ask me more questions about that. And I think now we're done with the language portion. We can go on to the next slide. I just wanted to, and this will be quick. This is a slide of some stakeholders in mental health. So you can understand all these different roles that people might play in the system. The first bullet is people with lived experience. Then you've got the family members and supporters, the treatment professionals, advocacy organizations, support groups, the media, government, society. This is not an exhaustive list. There's all sorts of ways that you can look at how people are stakeholders in mental health. And people can occupy multiple roles here. So people can be someone with lived experience who's also a treatment professional who works with an advocacy organization, attends support groups, and writes op-eds in the media. And those people exist. So there's people who go across the, and they could have a family member. And given the fact that there is some heritability, or that's the theory with mental illness, the likelihood is they might have some family member or friends they're supporting. So people might end up in all these roles, and there's a lot of overlap. But the idea here again is to be open to the fact that people are coming with a lot of different points of view. Next slide, please. Oh, I didn't even realize the slide changed. Sorry. So these are mental health professionals. So this is also just to give you the idea again. People might have differences of opinion of how to handle a mental health problem, and it could be due to their professional background. So this slide is just a quick overview of some of the professions in mental health, ranging from psychiatrist to psychologist, social worker or a therapist or a counselor, psychiatric nurse practitioner, primary care physicians can be prescribing these, prescribe psychotropic medication and be giving people treatment for things. And then you've got peer specialists. Really quickly, peer specialist is a new type of professional designation for someone with lived experience of mental illness who becomes part of a treatment team and gets some special training to be almost a liaison between someone experiencing mental health issues and the rest of the treatment team. So the idea is someone who's been through it can help mentor them through the process. So these are all different roles that people might have just amongst professions, and there's different schools of thought. I have other slides that I cut out of this presentation within, let's say, a psychologist. What theory of psychology are you applying when someone comes into your office? So the point again, and you'll see from all of these slides, there's a common theme. A lot of different ways to look at things, a lot of different language, a lot of different roles, a lot of different opinions amongst those roles. So just keep open to everything that comes in, and be ready to hear from different perspectives. So next slide, please. So this is I'm going to do this pretty briefly, but normally when I give a presentation, this ends up being 45 minutes to an hour. Just explaining, so I give a lot of trainings to mediators, people who are neutral conflict resolution professionals who might experience clients who are living with mental illness and in conflict with other people. And I try to teach them what I call cultural sensitivity to mental illness. And part of that is I go through some of the experiences that someone might have had and endured on the way to the mediation table. So that way the mediator can understand why someone might be reacting in a way that objectively looks intense if you didn't understand the history behind it and some of the challenges that the person had faced before they came to the mediation. And so this slide is an overview of some of the challenges that someone would experience if they're coming in with lived experience of mental illness. So some of the sensitivities. So in addition to the symptoms of their mental illness, there's a high likelihood that someone would have experienced some kind of forced treatment, which could include being in restraints. There's a good chance people have had hospitalizations. There's side effects from the treatment. There's life interruptions from having to go take care of yourself, and there's lost relationships along the way. For treatment challenges, there's a shortage of resources. It's hard to find someone to give you care because we don't have enough mental health resources in this country to take care of everyone who needs it. There's an inability to afford the care. There's trouble finding the right fit, so finding a clinician that works for you, an approach that works for you. There's differing medical opinions to go with, I believe it was it Teresa's question before? Or I think it was Teresa who said that. It was someone before asked the question about what happens when someone says one thing and another person says another thing. The treatment doesn't always work. So that's a popular misconception, is that people with mental illness should just go get their diagnosis, take their meds, they'll be all better. That's that. I've heard that a lot along the way in my travels, and the truth of the matter is treatment doesn't always work. So there's a lot of struggles trying different treatments, and when it does work, it might not work all the way. So just because someone's experiencing some kind of improvement doesn't mean they're all better. The next couple of bullets are about an individual determining limits. So what's me and what's my disorder? When should I seek support? This is insecurity capacity, but I mean for it to say capability. So what am I able to do? And last, we've got the new position in society. So people's expectations might change once they know you have a diagnosis, and even if they don't know you have a diagnosis, you might know you have a diagnosis, and you know that in general people have different expectations for you. There's something special about being dismissed as ill. It's different. I always tell people it's different than when people used to say I was a jerk and walked away from me. Saying that I'm ill is a very different thing. And being treated paternalistically is an important one that I'll highlight now, just to say, for some reason, when someone identifies as having a mental illness or a mental health issue, people around them think that it's their job to fix them and take care of them. And at this event, as facilitators, your job is to give people an empowering space for a conversation where they're treated as equals. So we're not going to treat someone like it's our job to take care of them because we know they have lived experience with mental illness. And that's hard to do even as a peer. So when I'm facilitating support groups and someone comes in and I know they have a diagnosis and they're my friend, sometimes it's hard for me to not want to try to help them more deeply than I would someone else because I think they might be in distress. But there's different roles at different times. So we would hope that during this dialogue, people don't feel like they're treated paternalistically. Next slide, please. So I also do a talk about what it means for a supporter to live with dealing with mental health issues and what it means for a professional. And this is a snippet of that and some of the challenges that they experience. And I'm sharing that with you also so you have some brief exposure to the ideas of what people might be coming in with. And again, this is really truncated from what I normally do. So normally these two slides together could be an hour and a half worth of material, and I show video clips of people experiencing some of this stuff. So this is really condensed. But a supporter, so someone who's helping someone with mental illness or mental health issue or mental instability or whatever we're calling it, they have direct trauma of mental illness. So by that I mean, when I got sick and I had my first episode, I had 6 friends with me, and that was their first episode too. They were there for that. They were in the room experiencing the symptoms when I did because they were part of it. And so they have the direct trauma and their own personal experience with actual symptoms of mental illness just by being part of the event of the mental instability. Supporters are often struggling with limited information. So that means that I always know everything I've thought about. I know all the thoughts that I've had, whereas if my family, my sisters, my parents are concerned about me, they only know what I told them, which is very little. I know everything that happened when I was meeting with my psychiatrist. My family might know nothing. And so supporters are often operating with limited information. They're also dealing with the shortage of resources I mentioned earlier. So if I'm in this hospital, my family is looking to get me help, or my friends are looking to get me help, it's very hard to find help because there's not that many resources. There's confusion regarding expectations. What that means is earlier on the previous slide, one of the things I mentioned is that people might have lower expectations of someone when they're dealing with mental illness. As a supporter, you might not want to feel like you're pressuring someone too much. So the low expectations is not necessarily a sinister thing or a bad thing. It might be that you're trying to let someone understand it's okay to not feel an excess of pressure that was there before. So it's hard to know whether to tell someone, oh, you'll overcome this and put a lot, which might put pressure on someone, or to tell someone, oh, aim lower, which might feel stigmatizing. So that's a difficult place to be in. And then there's the question of feeling responsible about the illness or not catching it. For professionals are dealing with many simultaneous cases, so that if anyone's ever been a professional of anything, you know that when you're dealing with a lot of simultaneous cases, you take a different view of them than if you just had one person you were helping. It becomes more of an aggregate view. So that changes someone's perception, and that's a different way of looking at things. Professionals are seeing people at their worst. So I know when I see my mental health professionals, I always tell them the worst things that have happened in my life because I'm looking for help with that. I don't tell them all the great stuff. And so that's a different view as well. Expectations are affected by past clients. There's a fidelity to professional lens, which means different people have different approaches in their different schools of thought. So different types of psychologists some will do cognitive behavioral therapy, some will do psychodynamic. And so they'll look at things through that lens. They did a lot of training, so that has pros and cons. And then they're also dealing with the same idea of limited resources. Where to refer patients or clients or consumers for help. So that's a real quick overview of some of the challenges people are experiencing in these 3 different dimensions, just to give you a flavor before the event of where people are coming from with their perspectives. And that's the end of my lecture about perspectives portion. And now we can move into talking about the actual event. So next slide. So I want to talk to you now about welcoming diverse perspectives to your event. And the first question is, how are we going to locate different perspectives to come here? How are we going to get all these different people to come to the event? At our event for the MH Mediate one, we reached out to a lot of different organizations. I opened up my Rolodex and contacted people from all these different communities I was involved with. And now your challenge is to make sure that when you're preparing your event, you reach out to all the people you can to get a lot of different people. So the first is professional associations. For any kind of mental health profession, there is an association, and you should contact your the national association and then any local prongs they have or committees, or maybe they have affiliates. Get in touch with professional associations to find providers in addition to contacting actual services. You can also, at the bottom of this list, I put the state or local office of mental health. They also could definitely put you in touch with local resources where professionals or might be running treatment programs that you can reach out to them to invite both the professionals and the people going to the programs. So the next bullet point here, the second bullet point, is NAMI state and local affiliates. And these are all links, and if they don't work, hopefully they'll work in the published versions of the slides. So NAMI state and local affiliates, this is the National Alliance of Mental Illness. It's a mainly family member organization that also involves people with lived experience of mental illness, and you can contact their affiliates to get them to come to the event. We had someone come from our local NAMI at our event. They have a lot of people. They often have support groups or other programs that they can promote the event to. So NAMI is a good resource. The Depression and Bipolar Support Alliance, DBSA, they have state organizations and support groups that you can reach out to. The National Empowerment Center has a list of consumer-run statewide organizations. Now you know what consumer-run means. Consumer-run means people with lived experience. So you can speak to the National Empowerment Center and look through their list and contact their organizations that are close to you. Mind Freedom International has a directory of mental health alternatives, so you can invite the people who are providing alternatives to the medical model and treatment, and you can get them to come. You can ask them to get their clients or peers or users to come. There's clubhouses and support groups, so you can Google in your area what's the local clubhouse, what's the local support group, and invite them. We had a few people come from Fountain House, which is a clubhouse model. Clubhouses are places where people can go. Sometimes they can live in clubhouse facilities, but places where people with mental illness can go to spend the day and have activities. And when you speak to all these groups, ask for referrals to other groups. So this is a lesson. This is a life lesson that was taught to me. But always say, is there anyone else that you can think of that I could invite to this event? I'm looking to get a diverse event put together. What other perspectives do you think should be included? Who should I reach out to? So ask for those referrals, because that's a great way to get that help. And they might also just email it out to the person for you, which is great. And that worked out with some of our people who came. It was like a cascade of forwarding that information. So next slide, please. So now, once you've located the perspectives and you're inviting them, how are you going to appeal to all these different perspectives? And the first thing is to emphasize neutrality and diversity in your written materials and in your opening remarks. So you can view my opening remarks on the website that I linked earlier from the MH Mediate event, and you can see that I really stressed we're going to work hard today to be neutral and diverse and empowering to all, and maybe put that into your literature when promoting the event. Also stress that this is not a support group, but a place for people to brainstorm and share ideas. So you'll see that in our opening remarks as well. We said you're coming here to think about these topics, share the topics, but we're not here to support one another. So that means if someone comes to a support group that I'm facilitating and someone comes in who's in real trouble, we might spend the whole support group talking to that person. But here's a place where we're going to really keep time and make sure everyone has an equal chance to speak, because we're talking about brainstorming and sharing ideas. We're not talking about supporting any individual. And the last thing is you're going to validate every perspective you hear. So this is important for the training with the facilitators, but make sure that above all else, everyone's feeling validated, and stress that when promoting the event. Next slide, please. And now we have some day of event tips. So I've been hinting at this, but we're going to train facilitators to be neutral and validating. So that's their main event. Make neutrality and diversity a common goal. So at my event, and the third bullet point goes with this. I asked the participants to set an example of diverse perspectives collaborating. Like Mary said, we were the first non-lead site to do this. So I said, we're setting a precedent here. We're inviting a lot of different people to come together. And the hope is that all of us will be an example for other people to, to be able to collaborate even though they have this different point of view, and to figure out neutral ways to talk with one another. And that really helped. People were really on the same team and united in that goal, even if they had different perspectives. So those 2 bullet points are really about getting people on board with the idea of connecting to other points of view. I mentioned earlier we're going to ask participants to assume the best intentions. So that's one of the guidelines that I had all the facilitators put in every group, and that's something that I said at the beginning of the event to everybody, that that we're here to support one another in doing this activity of brainstorming and sharing ideas. Let's assume best intentions in that. One guideline that people who have facilitated before probably have seen is ask participants to speak from their own experience. So I stress that when we're talking today, we're going to speak from something we've experienced, and we're not going to talk in generalities, and we're going to really strive to do that, and that's what the facilitators are going to help you do if something comes up where people do start speaking in generalities. And lastly, we use timekeeping as a fair way to move forward. So people might feel slighted if you move along from one topic to another, but if everyone understands from the outset that this isn't a support group, and we are keeping time, and the facilitator's goal is to keep us on task, to work through a pre-designated list of questions that we're going to try to cover and give everyone an opportunity to answer, that becomes a nicer way to move forward than sort of whimsically based on the facilitator's intuition. So those are the ways that we did it the day of our event, to make sure we welcomed all these different perspectives. And I think this is our last slide. So I think the next slide is my contact information. Is that right? Oh, more webinars. So if you want to go to more webinars, you can go to this website and see the new webinars and look at the old ones, and you can see a video of this one. You can share that video with your friends if they want to look at it, and you can see the slides. And then the next slide.
And the next slide.
Yeah. So this is my information. If you want to contact me, that's my email address, dan@mhmediate.org. I encourage all of you to contact me. You can also sign up for my mailing list if you want to learn more about the different projects that we're working on to help different perspectives connect. And if anyone wants to ask me questions now, we can do questions. Just want to get this information up here for anyone who wants to contact me.
And I'm not seeing any questions right now, but just so everyone knows, we will send the slides out along with the link to the video in case you'd like to watch that later.
Okay, well, great. Well, thank you all. I mean it. Feel free to reach out to me anytime. It's dan@mhmediate.org. You see it written there. And I'm interested in connecting with everyone, all the different stakeholders in mental health, all the people who want to help people have conversations. So really, please don't be a stranger.
One quick comment from Kim Crowley. Just talking about the online dialogue that we've also established, which you can get to from our website. And she said that it's a good place to see some examples of how people are talking about their experiences. So I'll also send out the link to the online dialogue that we have going on where people are discussing their various experiences as well. So thank you, Kim.
And this was Mary Jacksteit, just to say that if you contact us through our website saying that you're working on a conversation or thinking about having one, we have a team that can respond to questions, specific issues that you want to get some feedback about. So feel free to use that contact us mechanism on the website. So I think we are, Raquel, if my time is correct, we're at the end of our hour. Are there any more questions? Is there anything that you're seeing that we should look at before I say thank you, Dan, very, very much. Thank you all for joining us on the webinar. We appreciate your interest in what Dan had to talk about this afternoon and in the idea of getting Americans talking about mental health. So. Thank you all very much.
Thank you.
Thank you, everyone.